Hi there. My name is Eric Bank. I'm one of the medical oncologists at Ridley-Tree Cancer Center. Today, we're going to be talking about survivorship, and the data that we talk about and the recommendations that we talk about are adapted from the NCCN oncologic guidelines on survivorship care. So let's talk first about what we're going to talk about today. We'll define what survivorship is. We'll talk about the general principles of care for cancer survivors, which include screening for new primary cancers. We'll talk about immune system effects from cancer and cancer treatment, and we'll talk about some of the long-term side effects for cancer treatment, which become more and more relevant as time goes on from someone's cancer diagnosis. So to talk about what survivorship means, the definition that's used by the committee that oversees cancer guidelines is that an individual is considered a cancer survivor from the time of diagnosis, during and immediately after treatment, and throughout the balance of his or her life. The diagnosis of cancer can have a vast and persistent impact on an adult survivor, including the health, physical, and mental state, health behaviors, professional and personal identity, sexuality, and finances. In short, survivorship is focusing on the entire care of the person after his or her cancer diagnosis, because as those of us who are cancer survivors know, a cancer diagnosis and its treatment can have profound effects on every domain of life. Let's talk about what survivorship care should include. So survivorship care, meaning the medical care that's delivered to cancer survivors, includes many different things, one of which is surveillance for cancer spread or recurrence. So when someone comes to see me or one of my colleagues and they're a cancer survivor, one of the things we focus on is the cancer back? Do we need to do any additional testing? Are there any symptoms or exam findings or lab findings or imaging tests that might suggest the return of the cancer? Different parts of the physical exam are particularly important for this, and the type of cancer that someone has can affect which parts of the surveillance monitoring are most important. For example, for lymphoma patients, the lymph node exam is going to be very important. For breast cancer patients, a breast exam is important. For some patients with a cancer that is primarily detected on lab tests, the lab tests are going to be more important than the physical exam. Another thing that is done for survivorship care is screening for subsequent primary cancers. So for example, someone who's had breast cancer on the right side still will get mammograms on the left side, not to look for a return of the original cancer, but primarily to look for a second primary cancer on the other side. Similarly, someone who's had melanoma, for example, will go see their dermatologist and get a skin exam regularly, because someone who's had one melanoma is at risk for getting additional skin cancers in the future. Then let's talk about monitoring for late effects of cancer, because this is also an aspect of routine medical care for someone who's a cancer survivor. We'll talk in more detail about this later, but in short, there are psychosocial, physical, and immunologic effects from the cancer. And those are part of monitoring and cancer care for survivors as well. For some patients who have a cancer syndrome, there are additional things that come into survivorship care. For example, Lynch syndrome prompts additional endoscopy and colonoscopy. MEN is a condition where people can get multiple cancers in different hormone organs or glands, and other cancer syndromes require different additional, sometimes highly specialized aspects of survivorship care. Finally, sometimes the medical oncologist acts as a bit of a quarterback with regards to coordination for primary care and other specialists with regards to someone's survivorship cancer care. Let's talk about the planning that is involved and the plans that can be sometimes made specifically for patients about their survivorship care. So sometimes, especially if a patient is going to be moving, it is worthwhile to get an official, explicit, printed survivorship care plan. Another time when this is quite important is when someone is a pediatric cancer survivor and is going to be moving from pediatric oncology to adult oncology. Included in a survivorship care plan is often information on all the treatment that was received, information regarding follow-up care, surveillance, and screening recommendations, information on post-treatment care needs, including acute and late treatment-related side effects, delineation and assignment of the roles for the various healthcare providers to make sure that things are coordinated well, and then information about behavioral changes and behavioral recommendations that can be implemented to help keep someone healthy. Let's talk about an example. So let's imagine that Johannes is a 65-year-old gentleman who had head and neck cancer last year and was treated with chemotherapy and radiation together, often abbreviated chemoradiation. He had a feeding tube temporarily, but now he's done with treatment. He's eating by mouth, and he has no evidence of disease on laryngoscopy by his ENT, meaning the ENT goes in with a camera and looks, nor on PET scan. So this is a classic cancer survivor, right? If he were to have his survivorship plan spelled out explicitly, it would include the dose of the cisplatin chemotherapy that he got, the dose of radiation that he got, and the areas of lymph nodes that were included in the radiation plan, the names and contact information of the doctors who treated him. It would also include instructions for future care, which would include regular nutrition assessments, management of swallowing dysfunction, which unfortunately is one of the common late side effects of chemoradiation for head and neck cancer, management of dry mouth, which is a very common chronic side effect from radiation to the mouth, head, and neck, and exercises to prevent lymphedema of the neck and face. The survivorship plan would also specify that the patient needs regular lymph node exams by the oncologist, regular laryngoscopies or mirror exams by the ear, nose, throat doctor, annual thyroid blood tests to monitor for thyroid side effects from the radiation, and frequent checkups with the dentist, because people who have chronic dry mouth and who have gotten radiation to the mouth or the throat are at high risk for significant dental disease, which can unfortunately become quite complicated quite quickly if not caught early. And then a survivorship plan for a head and neck cancer patient would also include instructions to reinforce abstinence from tobacco and alcohol, which are common causes of these cancers and related cancers. Let's talk more about screening for subsequent new primary cancers. So unfortunately, amongst cancer survivors, there's a higher rate of getting additional cancers, which seems particularly unfair, but is the reality. Some of it is that some people have hereditary cancer syndromes. Some of it is that there are certain exposures or risk factors that are shared between multiple cancers, the most common of which is smoking or tobacco. But there are others as well, such as obesity, alcohol, toxin exposure, such as organic solvents, and HPV, which is a virus that is associated as the causal agent for several cancers. Additionally, in rare cases, the cancer treatment for the first cancer can increase the risk for a second cancer. In particular, there are certain chemotherapies that can do this, and radiation can do this as well. It's worth noting that the risks for those second cancers are very low, and that those treatments that do increase the risk for subsequent cancers are only utilized when it is clearly worth it to save someone's life from the first cancer. Then health behaviors should be modified as much as possible to reduce the shared risk factors for additional future cancers, such as smoking cessation and weight management. There's often a lot of coordination that is needed to make sure that the follow-up screening goes smoothly. Communication between primary care, GI, dermatology, breast radiology, the surgeon, and many other things. Let's talk about a couple of examples. So Tycho had bladder cancer related to his smoking. He's a cancer survivor, but because he was a smoker, he needs CT scans to screen for lung cancer. Vera had anal squamous cell cancer. That is a cancer that is almost always related to HPV, which is a virus. She's a survivor, but she needs regular pap smears because HPV is also the cause of cervical cancer. Edwin is another patient who's also a cancer survivor. He had melanoma, and he is on pills that target BRAF and MEK. These are treatments that are used for some types of melanoma, also certain other cancers that have a BRAF mutation. He needs regular dermatology exams because the BRAF inhibitor increases the risk for getting different type of skin cancer. And then Galileo is another example. He had pancreatic cancer 5 years ago, and he was found to have a BRCA2 mutation that he inherited that runs in his family. He needs PSA blood testing as screening for prostate cancer because prostate cancer is also a cancer that can be caused by a BRCA2 mutation. We'll talk now about the immune system, which can be affected profoundly by both the cancer and the cancer treatment. This would have been a different talk before the pandemic, but it becomes particularly relevant during the pandemic for all of our cancer patients who are immune suppressed. So for all cancer patients, and this is true of everything prior to the pandemic as well, there are immunizations that are recommended and that are particularly important after someone has gotten cancer care that results in immune suppression. So for example, there are vaccines that are routine vaccines that everyone should get, such as pneumonia vaccine, shingles vaccine, and those vaccines are particularly important when someone's immune system is weakened by either having had cancer or by cancer treatment. Also, as is in the news frequently, COVID vaccination is probably the single most important thing when it comes to saving lives from COVID, and also in terms of protecting the people who are immune compromised around us. There are certain special situations in which patients have had stem cell transplants or bone marrow transplants, such as patients who have had myeloma, certain relapsed lymphomas, and some patients with acute leukemias, such as AML or ALL. The stem cell transplantation process wipes out the immune system's memory for having learned from prior immunizations. And because of that, there's a whole revaccination series that happens when someone has had a stem cell transplant or a bone marrow transplant to repeat the vaccines that they got as a child to teach their new immune system post-transplant how to fight off things like chickenpox, measles, meningitis, and many other things. For certain patients with certain cancers or certain cancer treatments, there are medications that are prescribed to them that are anti-infection prevention medications called prophylaxis. Some examples of these include acyclovir to prevent shingles. These are selectively prescribed only to the patients whose cancers and cancer treatments require them. Then with regards to the pandemic, one of the things that is very important for our immune compromised patients and for the patients around them is masking and COVID vaccination. One of the things that can be difficult is knowing how immune compromised an individual patient is. This can vary quite a lot depending on what type of cancer they've had and what type of cancer treatment they've had, as well as the time interval between now and their prior cancer treatment. This is something that varies quite a bit person to person, so it's worth asking your doctor specifically about. Let's talk about 3 examples, though, of patients who would fit into the categories of mildly immune suppressed, moderately immune suppressed, and severely immune suppressed. Isaac is a patient who has polycythemia vera, and he's on hydroxyurea, which is a pill. He is mildly immune suppressed. Carolyn is someone who had lymphoma, and last year she finished her last dose of R-CHOP chemotherapy. She would be considered moderately immune suppressed. Neil has relapsed AML, acute myeloid leukemia, and chronically has a very low neutrophil count. He is severely immune suppressed. And so these 3 patients will have quite different risks for infection, and therefore they will get quite different treatment and recommendations from their doctor. Let's turn our attention now to cardiovascular disease, and we're going to start talking one by one about different late side effects of cancer and cancer treatment that can be managed and for which the risks can be reduced. Cardiovascular disease is the medical term for diseases such as heart disease, such as heart attacks or heart failure, circulation problems, such as blockages in the arteries that feed the head or the legs, as examples, and strokes. So there are some shared risk factors that increase the risk for both cardiovascular disease and cancers. The biggest one of those is smoking. An additional one is obesity. These are risk factors that can be reduced both to reduce the risk of a recurrent cancer or a second primary cancer, and also reduce the risk of getting cardiovascular disease. Because, for example, it's really a bummer if someone has their lung cancer cured and then a year later has a heart attack. 3 other factors that can affect cardiovascular risk include radiation, if that radiation includes an artery, for example, or the heart, for example. A class of chemotherapy called anthracyclines, the most common of which is called doxorubicin, which increases the risk for heart failure years later, especially in patients who have other heart disease risk factors, and anti-hormone treatments, such as ADT, or androgen deprivation therapy. Because we know that patients who require these treatments as part of their cancer care have an increased risk for cardiovascular disease, we often recommend to these patients when we see them in follow-up years later that they really do their best to try and manage things like diabetes, high blood pressure, smoking, and avoiding unhealthful foods as well. Because all of these things will reduce their risk for both cardiovascular disease and also, if in certain cases, cancer recurrence as well. Let's talk about the psychological side effects. There's a lot of research actually into the psychological side effects because, as any cancer survivor can tell you, these side effects can unfortunately be profound, severe, and long-lasting. The research into psychological side effects from cancer and cancer treatment divides them into 4 main categories: anxiety, depression, trauma, and distress. One of the things that's most important to know, and that I try to remind my patients, is that these symptoms are unfortunately very common. And it is normal to have symptoms such as anxiety when you've had cancer in the past and you worry about a recurrence. It is unfortunately common to have some trauma from the incredibly difficult experience that is having a cancer diagnosis and hopefully having it cured, but not without cost. And there are many different types of distress that can happen as well. Because this is such a common set of side effects in survivors, there's quite a lot of research. And fortunately, there have been also quite a lot of things that have been shown to be effective. So some of the easy things that are proverbial low-hanging fruit when we're trying to help someone with psychological side effects of their cancer care include managing pain, managing sleep disturbances, because you can imagine that if you don't sleep well, everything else feels worse. Treating fatigue, treating any hormone problems that might be present because of the cancer or cancer treatment, and trying to treat substance use disorders, which have a positive feedback loop with psychological side effects in that each of them compounds the other. There are a number of things that are highly effective in managing psychological side effects amongst cancer survivors. These include mindfulness meditation, which is notable because it is one of the things that is free to everyone, is highly effective in clinical trials, and has no side effects. Other things that have evidence for their support include support groups, discussing things with social workers, the utilization of cancer navigators. Thankfully, at Ridley-Tree, we have quite a lot of supportive care programs, and in Santa Barbara as a whole, we have a lot of supportive care programs, thanks in large part to philanthropic efforts, and utilization of mental health professionals. There are even phone apps, yoga, and acupuncture. These are all things that have very good high-quality data showing that they are effective at helping with psychological side effects from cancer and cancer treatment. Regular physical activity and healthy nutrition also play key roles, and those are such big topics that they are addressed elsewhere in the lecture series. Then there are the pharmacologic interventions. So pharmacologic interventions include things like antidepressants and other psychiatric medications. Let's talk about a patient. So Carl had esophageal cancer and now has no evidence of disease. He's in surveillance follow-up. However, he does have symptoms of PTSD, including difficulty sleeping and anxiety. To manage these side effects from his treatment, he engages in twice daily mindfulness meditation. He sees a psychotherapist. He participates in the wellness walks at Ridley-Tree Cancer Center, and he does Tai Chi. All of these are things that have good evidence and are effective in managing the symptoms that he has as a cancer survivor. Let's talk now about cognitive function. So sometimes this is described as brain fogginess, sometimes it's described as chemo brain, sometimes it's related to constellations of symptoms as well. So first off, it warrants a medical evaluation. Sometimes that medical evaluation is just a really good history, meaning talking with the patient and really getting a lot of detail. It usually involves a physical exam and a neurologic exam. Sometimes it also includes imaging tests or lab tests. The management of cognitive dysfunction is unfortunately a little bit more difficult than some of the other survivorship chronic symptoms or late side effects. Some of the things that have evidence include organizational strategies to keep someone on track and keep someone organized using things like a planner or a calendar or phone apps as reminders. Trying to plan one's day so that the most cognitively demanding tasks are done at the time of day when someone's energy is highest. For many patients, this is in the mornings or late mornings. Engaging in routine physical activity, which has good evidence showing that it actually improves brain fogginess in cancer patients and cancer survivors. Avoiding alcohol, sedatives, and other things that alter cognition and sleep. And then for some patients, it's worth doing formal language therapies like speech and language therapy or occupational therapy, or even having a neuropsychological evaluation, which often involves, in Santa Barbara, unfortunately, going out of town. And it just depends on the severity of the cognitive dysfunction. Cancer-related fatigue is another very common symptom and chronic symptom. in patients who are getting cancer treatment or who are cancer survivors after treatment. The fatigue warrants a medical evaluation to see if there's coexisting reversible factors such as depression or sleep dysfunction, substance abuse, hormone abnormalities such as low thyroid function, anemia, which can cause fatigue as well, anemia being a low hemoglobin or low red blood count. Sometimes for cancer-related fatigue, physical therapy and occupational therapy can be appropriate to regain strength, regain mobility, and build good practices. There are a host of non-pharmacologic, meaning non-medication interventions that also have good evidence for management of cancer-related fatigue. Again, mindfulness meditation would be near the top of that list. Talk therapy, cognitive behavioral therapy for insomnia, massage therapy, nutrition consultations and recommendations from a registered dietitian, acupuncture, and bright white light therapy all have data supporting their use for cancer-related fatigue. The nice thing about non-pharmacological interventions for fatigue is that generally there are no side effects. As far as medications for cancer-related fatigue, there are stimulant medications such as methylphenidate, which is Ritalin, and similar medications if the non-pharmacologic or non-medication interventions are inadequate. Let's talk next about lymphedema. So lymphedema can cause a lot of confusion amongst patients because it can present in surprisingly varied ways. So let's define lymphedema. Lymphedema occurs when lymph fluid accumulates in the interstitial tissues, causing swelling of the limb or other areas such as the neck, trunk, or genitals. It's a common side effect of cancer treatment. It occurs on the same side of the body as the cancer treatment and is a result of dysfunction in the lymphatic system. The interstitial tissues is just a fancy term for the connective tissues, things like skin, muscle, bone, tendons, and all the linings that are kind of at the borders between muscles and bone. The risk for lymphedema is increased by surgery or radiation to the lymph nodes, especially in areas such as the armpit, collarbone area, which is called the supraclavicular area, the neck, or the groin lymph nodes. Other factors that increase risk for lymphedema in cancer patients and cancer survivors include obesity, localized infection in the area that was treated for the cancer, and pre-existing cancer in the lymph nodes. So for example, when you're talking about lymphedema in the arm due to a cancer in the breast or armpit area, whether the cancer is in the lymph nodes increases the risk for lymphedema. How many lymph nodes need to be removed for the purposes of cancer treatment affects risk for lymphedema. How much radiation and dose of radiation to the lymph nodes affects risk for lymphedema. Obesity, if someone has an infection afterwards in the area where they had breast surgery, for example, all of these things are factors relating to risk for lymphedema. As far as lymphedema prevention and treatment, the coordinators for these are generally the lymphedema-trained physical therapists, of which there are several good ones in Santa Barbara, thankfully. We'll turn now to talking about chronic pain. One of the main things with chronic pain in cancer survivors is that it's very important to know exactly how the pain originates and what subtype of pain it is, because the management of those different chronic pains vary quite a lot. So there are a couple of different major categories of chronic pain amongst cancer survivors. There can be neuropathic pain, meaning pain originating in the nerves. This could be from chemotherapy that has nerve damage as one of its risks or side effects. It can be from surgery, especially if the tumor happens to be near one of the major nerves. Or sometimes the cancer directly damages the nerves, such as if the cancer happens to be a nerve cancer, or more commonly, if it's a cancer that grows and presses and compresses the nerves. Some cancer survivors have muscle, joint, or bone pain. Sometimes this is from anti-hormone therapy or chemotherapy, or the cancer directly damaging the bones, which you can imagine would cause pain. Sometimes people have GI pain from cancer or side effects of their therapy. And overall, the treatment is highly dependent on the subtype of chronic pain and the cause and severity. Let's talk now about menopause symptoms and the hormone-mediated side effects that can occur in cancer survivors. So in short, there are three subcategories within this. One is temporary menopause, meaning patients whose cancer treatments trigger a menopause that then reverses with time. Real menopause in women, and hot flashes and menopause-like symptoms in men. So when women who are premenopausal, meaning women who have not yet gone through menopause, who are still getting their regular periods, get some chemotherapies, it can temporarily suppress their ovarian function, meaning it shuts off their period. So many women, for example, during a very stressful time in life will miss a period, or if they get very sick, they'll miss a period. Similarly, if someone gets chemotherapy, the body will sometimes temporarily shut off the ovaries. This can cause symptoms of menopause, but sometimes 6 months to maybe 2 years after the chemotherapy is done, the ovaries wake up, and someone who thinks that she is postmenopausal is not actually postmenopausal. One of the things that is unfortunate in the treatment of patients who have hormone-mediated chronic side effects as a cancer survivor is that oftentimes their cancer history limits the safety of hormone therapy. For example, we wouldn't want to give someone a hormone that can make their cancer come back. Men can also get menopause-like symptoms from their cancer and cancer treatment, especially in patients with prostate cancer who get anti-hormonal therapy. Sexual function and sexual dysfunction is something that is unfortunately often underreported because oftentimes patients don't want to talk about this, honestly, but it's very important for people's quality of life. Unfortunately, a lot of patients who are cancer survivors do have sexual side effects. This can include low libido, vaginal dryness, erectile dysfunction, or pain with intercourse, amongst many other symptoms. The treatments really depend on the patient's medical condition, medical situation, and what sexual side effects he or she has. Some of the treatments might include talk therapy, topical vaginal therapies such as lubricant or medicated creams, pelvic physical therapy, or erectile dysfunction medications. I think everyone's familiar with erectile dysfunction medications such as Viagra, but one of the things that many patients are not aware of is that there's specialized physical therapy available to help people with pelvic symptoms, including some well-trained, specialized pelvic physical therapists here in the Santa Barbara area. Sleep disorders is another major category of chronic side effects and late side effects in cancer survivors. There are a ton of factors that affect sleep quality, as everyone knows. Some of the ones that we focus on as doctors treating patients include alcohol, obesity, heart and lung disorders, especially lung disorders that affect breathing at night, endocrine disorders, meaning hormone disorders, medications, hot flashes, the need to wake up in the middle of the night multiple times to urinate, and others. Regardless of the cause of the sleep disorders, sleep hygiene can be very helpful. Sleep hygiene is the medical term for doing the behavioral things that help someone to sleep better. An example that I often use in describing this to patients is that when I'm trying to train my daughter to sleep well, there are a lot of things we do before bedtime to set her up for success and set us up for success so that we can sleep through the night as well. Adults can use behavioral training as well. So this is all called sleep hygiene. It includes having a regular sleep schedule, engaging in physical activity in the morning or afternoon, trying to increase one's exposure to sunlight during the day because bright light of the sunlight wavelengths tells our brains to wake up and it sets our circadian rhythm, reducing exposure to bright lights and screens before bedtime, which is something that is very difficult in the modern world, but looking at a smartphone screen right before bed is a recipe for telling your brain that it's time to wake up. Avoiding alcohol, nicotine, and caffeine in the hours before bedtime, and having a dark and quiet room at the right temperature. There's a specialized training program. It's called CBT for insomnia that I often recommend to my patients. CBT for insomnia stands for cognitive behavioral therapy. I'm not talking about marijuana. CBT for insomnia is a program that has very good evidence for improving sleep quality. And in multiple randomized controlled trials, it is more effective than Ambien. So let's talk about what we've talked about and just make sure that we're all on the same page. So we defined survivorship. As a reminder, an individual is considered a cancer survivor from the time of diagnosis, during, and immediately after treatment, and through the balance of their life. We talked about some of the general principles for cancer survivors, including surveillance for recurrence, screening for second primaries, monitoring for late side effects of treatment, managing hereditary syndromes when appropriate, and coordination of care. We talked about the immune system and the effects that cancer and cancer treatment can have on the immune system. Generally, it includes recommending vaccination, sometimes taking infection prevention medications, and has major implications for a pandemic and masking. And then we talked about the long-term side effects from cancer treatment. I'll close by again citing my major data source for this presentation, There are thankfully a number of very good online sources for patients and family members regarding cancer survivorship and cancer care. One of these very good sources, which also includes links to the other good sources, is here, NCCN, Patient Resources, and this is a set of guidelines for patients. As always, at Ridley-Tree Cancer Center and for cancer care in Santa Barbara, feel free to reach out to your own team for questions that are specific, and it is a pleasure to care for this community.